All right, Prof, are you ready?
You can continue, Frederick.
All right. Okay, so have the recording started? Abdullah, you
Yes.
just now have it. Okay, all right. Okay, so good evening, everyone, and welcome to our case by case basics episode 19, lupus nephritis. So for those audiences that are new to us, case by case basics is actually a long-term series and effort from the Academic and Career Planning Bureau since 2020, which is 2 years from now, 3 years from now, sorry. We have been talking about common or uncommon yet important cases in different specialties, such as pediatrics, surgery, internal medicine, and orthopedics, to get some insights on how to approach certain symptoms, signs, and cases under them. So if you guys want to study our previous episodes, kindly go to our MEDSOC YouTube channel to look at our previous episodes. So today will be our 19th episode, our very first episode this year, and also our very first episode that deal with nephrology. We will we will have our dearest special guest today, Associate Professor Dr. Wan Ahmad Hafiz Wan Muhammad Adnan. So good evening, Prof. Prof, will you like to say a few words?
Nothing, Frederick. Thank you very much for the invitation. We just get it on and see whether how will this lead us to the discussion. So I'm looking forward to it. Thanks.
All right. From our side, we are looking forward on how this discussion will turn out on too. So Professor Dr. Wan Ahmad Hafiz Wan Muhammad Adnan, from our audience knowledge, is a senior nephrologist in UMC. He studied medicine in National University of Ireland and proceed with MRCP in Royal College of Physicians. He's an expert in nephrology, especially with those kidney diseases, kidney biopsy, transplantation, and dialysis management. He's currently a member of the Malaysian Society of Nephrology. So let's react with a big clap to our very special guest today.
Cannot hear the clapping, eh?
But we
Only
can
see
see
the
all the,
clapping. Wow.
yeah, only
Okay.
can see the, yeah, this is our COVID batches on how to use all these kind of Microsoft Teams
And you do the love
stuff.
sign. Oh no,
Oh,
it's not.
love sign.
Microsoft Team does not have the love sign, eh?
Eh, got the love sign, got the love
Oh
sign.
really?
Everyone
Oh
can react with the
okay.
love sign?
Well, okay. Continue, Frederick. Yes.
All right, so today we will be presenting a case of systemic lupus erythematosus with mild renal manifestation. From there, we will guide to the conversation towards how our medical perspective on the renal involvement in this kind of systemic diseases, together with the clinical presentation of lupus nephritis and how to diagnose, classify, and manage it. So beforehand, we need to apologize that this case might not be a very classical case of depicting how lupus nephritis looks like, because we are unable to find very classical cases from our ward in UMC for current stage. However, I still insist on discussing this topic because of some of my personal factors. I personally never managed to have a lupus nephritis case discussed back in my internal medicine posting. So I really wish to discuss this topic because it can cover all the presentations a kidney can have. So hopefully today we can have a meaningful discussion with Prof. So as this will be a discussion session, we hope that everyone can actively participate and involve in the discussion, even though the question might be a bit difficult or even hard to answer. And every not so accurate answer from the audience will be a learning point for all of us. All right, so without further ado, let's proceed with how our case today looks like. All right, so now I will continue with the chief complaint. So the chief complaint, Miss Chu, a 44-year-old Chinese woman, presented in the nephrology ward on 4th of March 2023 due to shortness of breath. So history of presenting illness, it shows that there's a presenting of the worsened shortness of breath 2 weeks ago, associated with bilateral lower limb swelling for 6 months, which is worsening for the past 2 weeks. It caused our patient to have difficulty walking due to the heavy leg and fell down multiple times due to the swelling. However, there's not much major injuries due to the fall. There's also seen a very increasing in weight. There's some form of reduced effort tolerance, walking much more slower with breathlessness after walking for about 60 meters. There's a generalized pruritus, which was being told that it relieved by traditional medications. So for some of the chief complaint here, we put into some of the manifestation that our patient have. The first one is our patient do experience do have a complaint of alopecia, some form of photosensitivity, malar rash, and also the numbness and stiffness in hands, with fingertips changing some of the color from different temperature environment. There's some of the renal manifestation also with faulty urine for the past 6 months, nocturia for the past 2 weeks, twice every night. There is no hematuria or dysuria. For the cardiovascular manifestation, there is some form of autopnia with sleeping and using 3 pillows. There's some form of hematological manifestations such as anemic symptoms, such as feeling very tired and shortness of breath. And there are also some other non-specific symptoms, such as 2 to 3 episode dizziness for the past 2 weeks, with pale complexion noticed by family member, which shows the anemic symptoms, together with the fatigue for the past 2 weeks and chills for the past 2 weeks. There's no other symptoms such as joint pain, bone pain, myalgia, paroxysmal nocturnal dyspnea, other kinds of fever, loss of weight, loss of appetite, night sweats, no headache, no nausea and vomiting, no oral ulcer, no constipation or diarrhea, and no tremors. So for past medical history, our patient do have hypertension, which is on medications, and dyslipidemia and hypothyroidism, which all on medication and all on regular follow-up. And our patient do have sciatica, which is resolved after weight reduction. Besides that, apart from these medications, our patient do take some powdered traditional medication that being claimed by our patient to improve our overall body health. There's no past surgery done, no recent infection, and there's no known food or drug allergies. So from past family history, there is no significant past family history of autoimmune diseases. However, her mother do have hypertension, diabetes mellitus, and dyslipidemia, and her sister had breast cancer. From the social history, she is an ex-smoker for 60 years for 20 years. 2 years ago quitting and changed to vaping. She is a social drinker and do not exercise regularly. She has reduced her food consumption to reduce her weight for losing 26 kg within the 2 years. However, recently growing back again due to the bilateral leg swelling. Her occupation is an office supervisor. So for the physical examination itself, from the general inspection, our patient is alert, conscious, lying comfortably on the back, and there's not in any respiratory distress. From the peripheral examination, everything is normal. From the chest examination, there's no spider nearby, no scars, and no swellings. From the abdominal examination, there is no swelling, no distended vein. Abdominal was not distended and moved symmetrically with respiration. No shifting downwards, no hepatosplenomegaly. Kidney is not palatable, no renal fluid, and bowel sounds are normal. The lab examination shows that there's a bilateral pedal edema up to thigh, and there is some of the ulcer and redness on the left lower thigh, and tenderness around the surrounding redness. Yeah. So, Prof, do we want to continue with the investigation?
You want me to treat this as like a examination? Frederick, what year are you in?
I'm actually in a stage 3.1.
Okay, 3.1. So still good. All right. So all right, Frederick. So you have presented to me a case
Yep.
of shortness of breath. So do you mind to summarize the case so that people who are lost can kind of understand or recognize what are the main features of your history? Go on.
Okay, sure. Even though I have not much experience in summarizing case, but I will try my best to do it.
No worry.
So,
It will be
okay.
good.
All right. So, our patients today, Miss Chu, a 44-year-old Chinese woman, with no with significant medical history of hypertension, dyslipidemia, hypothyroidism, and sciatica, coming to the nephrology ward on 4th of March 2023 due to the chief complaint of shortness of breath for 2 weeks, associated with bilateral leg weakness and also faulty urine for the past 6 months. Yeah, from uh, from physical examination itself, there is no significant findings aside from the bilateral peding edema. Yeah, this is my short summary of how the
Okay.
patients.
And certainly I don't find any major problem doing that kind of a summary. I think most of the 3.3 they would summarize more than that.
Mhm,
And I think your summary, so the main important reason to have summary is
mhm,
because obviously, in the real history you have a lot of information to give.
yeah,
But your summary should be able to let the examiner or anybody who hears you for the first time to come up with some differential diagnosis. So the fact that you
mm,
say this 44-year-old female who was admitted with a 2-week history of shortness of breath,
yeah,
frothy urine and leg swelling,
mm,
with past medical history of hypothyroidism and so on and so forth. So
yeah,
even the shortness of breath, because when you say shortness of breath, the people will start thinking about what are the differential diagnoses of shortness of breath. But when we say
yeah, yeah.
frothy urine and bilateral leg swelling, and if you have other symptoms of SLE that you want to mention, such as joint pain,
Oh, joint pain and the
you
Raynaud
know,
phenomenon.
yeah, so then you can enter it as well in the summary, so to
Okay,
suggest to the examiner that I'm thinking actually this is SLE is my
SLE
primary.
disease.
Yeah.
All right,
So
understand.
yeah, so you don't need a long. So I think that short and sweet, and for the examination as well, you can do summary. But it is probably important to have certain important negative in this particular case. So for example, you
Mm,
say so on examination, so the general overview I think is important. The patient was comfortable, not tachypnic. Uh, and she actually has bilateral leg swelling, pitting edema up until to the
yeah.
knee. Uh, her lungs was clear. There's no bibasial crepitation and there's no sacral
Mhm.
edema. So just to put overall kind of a overload, fluid overload kind of a symptoms into the place. Okay.
Mm.
By the way, okay. So that's good. So give me the diagnosis or differential diagnosis.
Okay, so I think from my I think to make this discussion more interactive, how about
Mm.
we ask some of our audience on some differential
You call out their
diagnosis?
names and we'll see. Because obviously your presentation case by case basis is SLE already,
Yeah.
but it will be interesting even in the exam if somehow somewhere the patient told you what is
Mm-hmm.
their diagnosis. I've seen people fail even they know the diagnosis,
Yep, yep.
because their history does not lead to the diagnosis. And so yeah, so certainly even though we know this is SND case, you can ask your friends what kind of a differential diagnosis for patients who come in with shortness of breath, bilateral leg swelling.
All right. So let us ask some of our audience. Okay. Let me check.
You have 58 participants.
Yeah. Abdullah.
That's the first one.
Yep.
Okay, differential diagnosis for this
Uh,
case.
tell me your Abdullah. Tell me your year first.
Okay, I'm in stage 3.2 right now.
Okay, go on. If you still
Okay,
remember
so
last year.
a bit. So based on the differential, based on the summary, I think I would go for chronic kidney disease.
Why do you say so?
Okay, because of the presenting symptoms of progressively worsening bilateral leg swelling, accompanied with shortness of breath and also the frothy urine, which is a big clue, in my opinion.
Okay. What does it mean when patient says they have frothy urine?
Frothy urine means basically means that the urine is very bubbly and the bubbly remains after a long period of time. Usually the urine bubbles will actually disappear after a short while, but in frothy urine they remain longer. And clinically it actually means that there are presence of protein in the urine.
Okay. Okay, fair enough. So that's very good, Abdullah. So yeah, so our first differential diagnosis, CKD. Anybody in 3.3 now? To get some nuances or some a little bit more. Patrick, you know your senior, right? So pick one 3.3. They wouldn't blame you or
Okay.
you're afraid. You can text me, WhatsApp me, and then I can call out their name.
Okay, let me check from here.
Okay. I just want to ask a little bit more detail about the diagnosis.
Okay, maybe Kochian?
Oh, hi, Prof.
Hi, Coach Chen. Okay,
Hi,
you are in 3.3.
yeah, I'm 3.3.
Okay, good. So so Abdullah was saying CKD. Any additional thing you want to add?
Probably I also consider a pulmonary embolism because this patient have a leg swelling and there's a redness over the left lower legs. So it could be a DVT and then lead to a pulmonary embolism as well.
Okay, what makes this not pulmonary embolism?
Probably the chronicity of the presenting complaint.
Not really. This is 2 weeks, right?
Yeah.
Mm.
And it's a bilateral leg swelling. Usually in
Okay,
DVT, usually
that's
it's a unilateral.
So I think if you ask me, the main reason why we are not thinking that this may be pulmonary embolism is because of bilateral involvement of the swelling. Now, you have seen people with widespread thrombosis, and they could have bilateral DVT, but that's very rare. So we go with the common thing first. So yeah, so that is something you can think of, especially when you do chest X-ray, nothing was there. Okay. Now, another thing is about the Abdullah's diagnosis of chronic kidney disease. Have you had a medical rotation yet for 3.3?
Yes.
Done already, eh?
Yeah. I'm currently in my medical posting.
Oh, currently medical posting. I wouldn't ask. Okay. So from the CKD point of view, when we mention CKD, because CKD has a lot of range of problems, right? And you know yourself, there are how many stages of CKD? 5 stages of CKD. So when you mention in a case that a patient has CKD, what makes this case differ, as in diagnosis of CKD, and somebody else that you probably see in the clinic where they have CKD as well? So what is the difference between that CKD and this particular case of CKD? When you put diagnosis of CKD as your differential diagnosis.
What's the difference between?
Yeah, so when Abdullah put CKD as a diagnosis, right? You have seen CKD in the outpatient, and this is more kind of an acute
Yeah,
problem.
if it's a CKD, the time frame should be more than 3 months, and we need to compare if is this we need to differentiate whether it's an acute kidney injury or it's a CKD by comparing to the baseline and the previous baseline and where is the onset of the reduce in the kidney function.
Okay, that's correct. So, in a way, because we've been taught, comparing AKI and CKDs last longer. But there are CKD that previously, one day you were playing football with your friends, and the next day, you were diagnosed with end stage, and that is pretty severe. because sometimes CKD does not have any symptoms, and even though they presented with only 1 week history of something, but they may actually be CKD. So, duration of symptoms, although it is important, but it may not reflect the overall situation of a patient, right? But my angle of the CKD, and this is for everybody. So saying CKD only as your diagnosis, although as a 3.1, I think that's acceptable. Even 3.3, I think that's okay as well. Is this CKD is not enough. There are people with CKD stage 3, for example, and they actually don't have any symptoms. And even for somebody with CKD stage 4, they might not have many symptoms or might not have any symptoms at all. So what makes this leg swelling and frothy urine due to CKD, and usually this happens either the CKD is very advanced, that they're nearing dialysis. Okay, so you're talking about end of stage 4 or early stage 5 or end of stage 5. Because CKD in the early phase on its own would not cause this kind of leg swelling and shortness of breath. Okay, so although CKD, I accept it, but if you want to be a little bit more detailed, I would say, so my differential diagnosis in this case, one of it is advanced CKD or CKD nearing towards the end of its life, or advanced CKD would be my word of choice. Or you can say CKD stage 5, say CKD stage 4, stage 5, or end stage kidney disease, something like that. Okay, to differentiate between those who have CKD that does not really have much of a leg swelling and so on. Okay, other differential diagnosis apart from CKD or advanced CKD, apart from pulmonary embolism, other things?
Probably could be also a decompensated liver failure, since although this patient doesn't have any jaundice, but since patient has been taking a traditional medication, could be a decompensated chronic liver disease. Yeah.
Okay, fair enough. And what would you expect if somebody has a decompensated liver disease?
I would expect patient having like jaundice and then
Okay, fair
probably some
enough.
coagulopathy.
Okay.
Or
Let's call
hemochromatosis.
out other people. So you have liver disease or decompensated liver disease, advanced CKD. Anybody else wants to give other possibilities?
Sorry, Prof, I can ask a question regarding you
Can.
mentioned the probationer, right? Because usually, let's say a decompensated chronic liver disease or even a decompensated heart failure, usually there's an underlying cause that trigger the decompensation. How about for
Sure.
chronic kidney disease? Usually, is there
Same thing as well. So chronic kidney disease is not a final diagnosis. They usually have secondary due to something.
I see.
But yeah, so I tried to get all the relevant differential diagnosis, and then because the next differential diagnosis will require certainly something extra, and that how it leads to SLE. Because usually you wouldn't say in your diagnosis this is SLE, right? Because patient comes with overload and bilateral leg swelling and frothy urine, so you wouldn't connect it directly to SLE. Usually it goes through the middle ground, and that middle ground, I think nobody has mentioned it yet.
Thank you, Prof.
So other differential diagnosis. So we have CKD, decompensated liver disease. I include the decompensated heart failure as well, like Yojeng has mentioned, and then also potential PE, which is a bit unlikely. One more. Frederick?
Professor, I'm sorry, I'm from second year. I'm not sure. Is nephrotic syndrome a differential diagnosis?
Yeah, so that's the one I'm looking for. Thank you very much. What's your name?
I'm Prashwin.
Okay, Prashwin. So you are having your clinical day in nephrology now, right?
Yeah, but it's going to end already.
Next, you probably your group will probably end already. But anyway, yeah. So that's the one I'm waiting for. Partly because I know that when somebody's fully overloaded, we usually combine all three, right? Liver problem, kidney problem, heart problem. Now that's a general overrule, and that's quite all right. But I think a better student will try to look at a bit more detail, because saying liver problem is not enough. You want to say decompensated liver failure, because that's when patient have ascites, bilateral leg swelling, shortness of breath. And similarly with the heart failure, ACS would not cause bilateral leg swelling on its own. You have to have a decompensated heart failure in order for you to have basically leg swelling. And similarly with kidney as well. Having a kidney problem does not automatically say that you have bilateral leg swelling or become fluid overload. So there are two conditions that in kidney that may cause fluid overload. Number one is advanced CKD, like what we have mentioned just now, and number two is the nephrotic syndrome. And the reason behind why somebody has nephrotic syndrome or CKD, and that needs to be put in the particular diagnosis as well, okay, or in the discussion, even if you're not sure what's the cause of this, okay. So nephrotic syndrome is another one that I think is important, and that's how it leads to SLE or lupus nephritis, because that's how lupus nephritis can present with, because we are lacking of other symptoms like joint pain, malar rash, and other things. So nephrotic syndrome becomes something which is important. Okay. So again, recap again, the differential diagnosis in this case because of a frothy urine. So I would say top of the most is nephrotic syndrome. Second probably is advanced CKD. And then you probably have decompensated heart failure. Liver probably is out of the picture a little bit because there's no jaundice or no suggestion of any liver problem in the past. Right, back to you, Frederick.
All right, so I will continue with the investigation. Okay, so for the investigation, apart from the NIL gap, for the renal function itself, apart from NIL gap, urea and creatinine is low. There is no other significant finding found. For the liver function test, we can see that the calcium is a bit low. The troponin H sensitivity troponin I is a bit high, and the total protein is a bit low, which shows some form of the nephrotic features. And also, other than that, would be some of the deranged liver functions. For the complete blood count, we do see some of the anemic pictures and some form of the reduced white blood cell count. For the coagulation screen, everything seems normal. For the thyroid function test, the free T4 is a bit low. For the complement serum test for the immunology, C3 and C4 is low, and IgA is a bit high. Protein and albumin is low, of course, and alpha-2 globulin is high, together with the beta-2 globulin. The beta-1 globulin is a bit low. Yep, that's it for all the investigation that we managed to get.
Blood investigation, you mean, right?
Yeah, blood investigation.
Okay. Let's go back to the initial blood investigation and call out one of your friends. Or you want to start first? You haven't done SLE, right? So
Yep,
what do you see in here?
For the renal function test,
Up to you. I mean, I think one of the missing thing that students usually miss when they do the clinical attachment is that when they took the history, presented the history and everything. So I think make it a habit to discuss the results of a patient as well. Now, obviously, a patient has been in the hospital for 30 days, then a lot of things would have been done. So, I think that's most of it probably irrelevant for medical students. But the initial investigation when they were admitted, I think that's important, and having a discussion, understand the discussion would be important as well. For example, in this case, right? So go back to the renal function test and liver function test. Okay. So apart from looking at what is being highlighted, so instead we should probably ask what are we expecting or what kind of a test we do, and then what we want to see. Okay, so it's something like an exam. So if you were asked what kind of investigation you want to do or blood investigation you want to do, what would you do? Let's say you see renal function test. What do you want to see, Frederick, in the renal function test?
For renal function test specifically, I would like to see for the EGFR first.
Why?
Maybe to see how is the current kidney function of, is there any stages of any signs of chronic kidney diseases or any acute causing, and also maybe to look at the creatinine.
Okay. Why are you looking at the kidney function?
To
in this
actually
case?
to see if because our patients do show some of the nephrotic pictures, and we want to see if there any form of kidney injury going on. Even let's say it's acute or even is a chronic cases that we may look at the previous renal result, or is it more on the acute or chronic pictures?
Okay, so you are focusing on the acute and chronic, and that is relevant, particularly if, let's say, the serum creatinine is elevated. Okay, so when serum creatinine is elevated, one of the main key questions we want to ask is basically, is this just being elevated because of a current condition, i.e. AKI, or this has been elevated for quite some time, i.e. chronic kidney disease. Okay, but in particular, in this particular case, so another way to look at what investigation to do, what kind of a management you want to do later on, really depends on a good differential diagnosis. Okay, once you have the differential diagnosis, and once your differential diagnosis is covering a lot of condition or possible condition, then you can use that differential diagnosis to highlight the result that you want to do. For example, in this case, because one of our differential diagnosis is, let's say you say nephrotic syndrome, and nephrotic syndrome sometimes can cause elevation of creatinine. And more importantly, your second differential diagnosis is? Oh, my differential diagnosis, yeah.
Lupus nephritis?
No, the one that we were
CKD.
discussing.
CKD.
Yeah, so advanced CKD, right? So hence, checking the creatinine and urea becomes important, because one of our differential diagnosis is advanced CKD. Okay, so obviously, by looking at this result, you can rule out totally that this is not something of an advanced CKD that can cause fluid overload. Okay, so that's fine. Let's look at the liver function test. Okay, Frederick, so let's go through here. So I heard you mention many things. Okay, so some are low, some are high, and I will need a little bit more of a depth of the discussion, because saying high or low, I think we can see that, right? It's been marked H for high, L for low. So what is more important is, how do you understand this? How it relates to your differential diagnosis particularly, and perhaps what kind of a management. So what would you look at?
Maybe the hypoalbuminemia.
Okay, why is it important?
Because it depicts some form of maybe the nephrotic syndromes.
Okay, and you did not mention albumin just now. I know you know. You mentioned total protein.
No, yeah.
Okay, yeah. So usually we look at the albumin.
Albumin.
And this albumin of 6 is very low. Okay? Suggestion that the patient is losing albumin somewhere. Okay. What else is important? So you mentioned calcium is low, 1.8. Is that true?
Yeah, I mentioned about it just now.
True, yeah. But you look at it, the corrected calcium.
Corrected calcium is 2.4.
Why do you have a corrected calcium? I know it's not related to the case. Why do you need a corrected calcium? Why is there? Why the calcium has to be corrected? Nothing else is corrected.
This one I'm not too sure.
Okay. Anybody else know? Anybody?
Is it because the albumin will bind with the calcium?
That's right. Yeah. So when the albumin is low, the level of calcium that you get is not accurate. Okay. Hence, there are formula to calculate what actually is the level of calcium when the albumin is low. Okay, so that's why when they see the albumin is low, or the calcium is low and the albumin is low, then you have to correct for the calcium level, and that's when you get 2.48. And as a clinician, we took the serum calcium of 2.48 as a relevant one. Okay, so that means in this particular case, for internal medicine physician, we don't need to replace them. Okay, because the calcium is considered as within normal value, 2.48. All right. Got it, yeah, Frederick? Okay, good. So let's go next. So when you say LFT is abnormal, there's not much of abnormality in LFT though, when you say that. I know there's a L, there's a H, but in specific, nothing much abnormal apart from the albumin is low. So when people say LFT is abnormal, mainly they're looking at the ALT, AST, and gamma GT. Okay, and in here, although gamma GT is elevated, but it's not too high. So usually we say when the ALT or AST or gamma GT is like 2 or 3 times above the upper limit of normal, then it becomes more significant. Now you can say it's elevated, but it becomes really significant if it's more than 2 times of normal. So for example, ALT upper limit of normal is 50. So when it's 100, that becomes significantly elevated, and we have to look for the cause. Okay. Okay, next. And complete blood count. You did not mention one thing. What do you see here, Frederick?
Besides the anemic features and leukopenia, maybe the HCT.
Okay. What is the significance of this particular blood test in our discussion?
Maybe we need to look at any chronic kidney, any normal cystic anemia that leads by the chronic kidney diseases.
Okay, fair enough. But then from the first initial blood test, we know already that this case is not about chronic kidney disease, because the GFR and the creatinine are all normal. Okay. So other possibility?
Other possibilities. I'm not too sure.
It's okay. If it's associated with nephrotic syndrome, what?
Nephrotic.
Because I know nephrotic syndrome is nothing about anemia and other things, right? But you cannot really overlook this particular slide because the hemoglobin is low, which is quite common in somebody who's being admitted to the hospital. But another key features in here is that white blood cell count is low as well. Okay, and that's very rare for hospitalized patient, and we want to know why. So why?
Why is it because of the hypoalbuminemia that leading to the reducing cell count?
Near enough? No, not near enough. Okay, not really. It's not. It doesn't work like a calcium.
Oh, okay.
Okay, open to the floor. Why this patient has low hemoglobin and low white cell count?
Prof, doctor, could it be due to dilutional kind of changes because there's fluid overload?
Potential for anemia, but somehow we rarely see that with the white cell count. And I can argue that if the dilutional, how come the sodium is not low? And how come the other blood test is not abnormally low? So yeah, so we wouldn't blame on the dilutionals in this particular case. No, not really.
Or either a low EPO?
Low EPO, when does that happen?
When you have a chronic kidney disease.
True, but in this particular case, we have already identified the patient does not have chronic kidney disease because the GFR is actually normal. So we cannot put the low EPO in this particular case. And plus, low EPO does not cause low white cell count. Other people, I'm sure some of you would know. Just you need to come online. Frederick, pick one.
Okay, let me pick one here. Uh,
Oh, I saw
Um,
leaving already.
students nowadays just getting scared to being called out.
No
Maybe
worries, okay.
Eugene.
Hello,
I
Prof.
imagine, yeah, go on.
Hello.
Hi, how are you, Eugene? Thank you
Hi.
for not leaving.
Good evening. Okay, so
Good
I
evening,
think that
yes,
this
please.
patient has a long-term, this patient has a long-term like SLE picture. So a chronic anemia of chronic disease, anemia of chronic disease will have a picture like this, slightly anemic, as well as a low hematocrit, and also maybe the white cell count are low, maybe because the patient is probably on some steroid, which may cause the low white blood cell because steroids reduce the competency in someone. Yeah.
Okay. So Eugene, I like your link with the SLE because that's currently the topic that we're linking. So you're right. Some SLE can cause low hemoglobin, and thinking about immunosuppression causing low white cell count is good as well. But in particular, Eugene, what year are you in?
I'm currently 3.3, doctor.
Okay, thank you very much. So, in particular, low white cell count can be a direct effect of SLE. Okay.
Okay. I see.
And plus, certain immunosuppression in SLE can cause low white cell count, but it's not steroid.
Okay.
So other medication, I think for 3.1 is a bit too advanced, but other medication that can cause low white cell count, immunosuppression such as azathioprine as well as mycophenolate. So these two can cause low white cell count. Cyclophosphamide can cause low white cell count as well. So all these three medication that sometimes used in SLE. Steroids usually may cause high white cell count instead of low white cell count. But in this particular case, I would be expecting that, let's say somebody says, okay, my differential, one of the differential diagnoses is nephrotic syndrome, and nephrotic syndrome has a lot of causes, right? And because the patient has low hemoglobin and low white cell count, if you go through the cause of nephrotic syndrome, I think probably one of the main cause of this is SLE. So automatically, when you see this bicytopenia, then that triggers that, could this be SLE causing the nephrotic syndrome? Because another possibility is like multiple myeloma as well, because multiple myeloma can affect the bone marrow, but I think that's quite rare. Okay. All right. Okay. So let's go down coagulation screen. Eugene, can I ask you further question? Can I?
Okay.
It's okay. Easy lah. Don't worry. It's okay.
No problem.
Because we are talking about nephrotic syndrome, can you tell me a bit more about nephrotic syndrome that you understand?
For what I know, there will be like 6 grades of nephrotic syndrome. Sorry. That is SLE. Nephrotic syndrome is actually a triad where patients have proteinuria of more than 3+, associated with hypoalbuminemia and also hyperlipidemia. Yeah, and it can be due to many causes such as the post-streptococcal glomerulonephritis, diabetic nephropathy, can be also SLE, but SLE can be kind of a mixed picture or nephritic and also a nephrotic picture.
Okay. Okay, I'll save one more question to you, Eugene, but later on, okay? I want to ask the stage 2 because they just have their nephritic kind of clinical days last week. Stage 2. Stage 2. Question is, what causes nephrotic syndrome? Or give me the differential diagnosis for somebody who has a nephrotic syndrome. Stage 2. Eugene already mentioned some of it, so you can just repeat what Eugene says.
Prof, can I try? There's one right where you cannot see changes on the microscope, minimal change disease.
Okay, that's one of it. So generally, when we talk about nephrotic syndrome, I think a good answer would be it can be due to primary causes and secondary causes. Primary causes is all those things that you mentioned just now, minimal change disease and other glomerular nephritis that can cause nephrotic syndrome. So if you're familiar with your kidney, one of the answers is FSGS or membranous nephropathy. Okay, so I think you can revise that on your own. Those are the primary thing. The secondary causes of nephrotic syndrome can be diabetes nephropathy, can be hypertensive nephropathy, and it can be SLE as well. Okay, so that's when you come up with SLE in your differential diagnosis. Okay, now back to you, Eugene. SLE as the overall diagnosis of SLE. How do we diagnose SLE?
The diagnostic investigations for SLE are actually blood investigations such as anti-double-stranded DNA, anti-ANA, and also the elevated C3 and C4 complements.
Good. So I know you're not actually prepared, like reading, and I think that's a good ad hoc kind of memories. Okay, so double-stranded DNA elevated, anti-nuclear factor antibody elevated, and complement levels actually reduced, not elevated. So C4
okay.
reduced. Okay, but there are multiple others SLE. So like what Frederick was mentioning early on in his presentation initially, he was trying to look for somebody who has a lot of symptoms of SLE. And I'm telling you, you would not find somebody who fit 100% what's been described by the book of SLE. Okay, so some people has more of a musculoskeletal presentation. Some people have much more severe, and they have additional lupus nephritis presentation. And there are people who have seizure and they have other manifestation of SLE. And knowing how to diagnose SLE is important. I think there was a study before for glomerular nephritis, including SLE. Doctors out there take probably 1 year from the initiation of symptoms until the diagnosis. And that's how it can be very difficult to identify these autoimmune disease involving the kidney because the symptoms can be variety of them. Okay, because imagine if you have a joint pain, you won't be thinking seeing rheumatologist or you won't be saying kidney patient, kidney doctor first. You're probably going to see like orthopedics or something like that, right? So yeah, so a wide variety of things. Okay. Okay, so that's good. Nephrotic syndrome and in the differential diagnosis includes SLE. And Eugene has mentioned some of the diagnostic criteria of SLE. Go ahead, Frederick. You have 7 more slides. Immunology. Okay, let's go immunology. So what can you see in here? I think you can combine what Eugene was mentioning just now.
Okay, what I can see is the complementary serum C3 and C4. The IgA is
High or low?
high.
C3, C4.
Oh, C3, C4 is low,
Yeah, so
which
I
does
think,
not depict the which
Okay.
does not depict the picture of SLE.
which
Maybe
what you said?
does the low C3, C4 depicts the picture of SLE?
Defeat?
Depicts.
Oh, yes, that's right. Yes. So it does really
Oh.
suggest that this case is SLE. Even before you're doing any biopsy or something like that, having a low C3, C4, low hemoglobin, low white cell count, frothy urine, overloaded. Yeah, I think that's easily SLE kind of everywhere. A picture of SLE everywhere because SLE is a multi-system kind of a problem. Okay, but somehow in this case, people are sending a lot more immunological kind of a test. And since you have it on your picture, do you know what is those serum protein electrophoresis? And they have IgG, IgA, IgM, whatever it is that you have there. Just to make sense, I mean, when you attending the ward, you probably want to ask, what is that? Why are we sending those? Why?
Is it because we want to see the especially for the immunoglobulin level and the globulin, because For previously we talked about nephrotic, there's a hypoalbuminemia, right?
Oh yeah, true. So you may losing some of the immunoglobulin. True. Now you put it that way. But I'm sure one of the reason they sent this is because the patient has nephrotic syndrome and they want to outrule myeloma. So when you see multiple
Oh.
myeloma, this is the most common test that they send out just to detect multiple myeloma. Okay. So all nephrotic syndrome, you don't need the serum protein electrophoresis. Especially for SLE, you don't need those. Okay. You can make diagnosis without serum protein electrophoresis. So most of the hospital and most of the cases, we don't need this serum protein electrophoresis unless you really suspect you are dealing with multiple myeloma.
Okay.
Okay. So you have ANA there, 1 in 80.
Yeah, 1 in
Okay.
80.
1 in 80 is actually low. So which one is higher? Which one is more significant, Frederick? 1 in 80 or 1 in 206, 256? What do you think? Which one is more significant? Oh, 1 in 1,280. But it's a 1 in, not the level, not the 1280, but it's 1 double dot 1280. What do you think, Frederick?
Sorry, Prof. Just now the Wi-Fi a bit off. It
Oh,
disconnected.
my Wi-Fi. Sorry.
My Wi-Fi.
Oh,
I'm
okay.
sorry.
All right. So
I think it's
between
my Wi-Fi.
1 in 80, so you see the ANA level there, 1 double dot 80. Okay, that means 1 in 80 compared to, let's say, 1 in 1,200. Which one is more significant if you see that kind of a 1 double dot?
The second one.
The second one. Why?
Because
What does it mean? Why?
because
What
it
needed?
means I think it means that when it dilutes until that time, when
Okay.
you still see that. It
Very
means that
good.
it's-
Okay, yeah. So that's what it is. So 1,280 means that when you dilute, you can still see the positivity of it, and that means it's quite significant. Okay, anyway, so you have rheumatoid factor and you have DNA or ENA specific serum. Okay, so that's quite good. For somebody who has autoimmune disease, especially SLE, you can have some positivity in extractable nuclear antibody. Okay, so you can see there as well, it was positive for what?
it was
ANP and
positive for RNP
I
and
can't
SM.
remember. RNP and SM. Okay, Smith antibody. So anti-Smith antibody is also hallmark for SLE. Okay. There's another one, the result in progress. That's another hallmark for SLE, the double-stranded DNA. In this case, it's still in progress, but I'm sure it would be positive most of the cases. Yeah. Okay. So you can see in real life that people are sending all this autoimmune disease because they're already suspecting we are dealing with SLE. The complement level is low. The ANA is positive. They send double-stranded DNA, and anti-Smith antibody is positive as well. So we are dealing with SLE. Okay, next.
I think that's it for the investigation. Other
Okay.
things such as the proteinuria, other investigation, I don't see them doing it.
Oh, you don't see them doing it? That's very poor. What would be other investigation, Frederick, that you expect the doctor will do?
Maybe to check for the proteinuria.
Okay, how do you check for proteinuria?
Proteinuria, wait. UFEME.
Okay, and any other way?
Urine dipstick.
So urine FME and urine dipstick is something similar. Urine FME practically is urine dipstick, only that in UM we send it to the
Okay.
lab.
I think that. Okay, I'm not too sure.
Not too sure. Okay, so there are, I think stage 2 should know as well because they're just completing their nephro clinical days. Nobody else, eh? I think I'm back to Prashwin. Sorry, Prashwin. Nobody else is here from stage 2. I'm not sure whether they're not Say,
Prof, sorry, can you repeat the question? My line is also breaking.
okay. If everybody's line is also breaking, that means my line is actually not so good. But what was my question again? How do you check for somebody having proteinuria?
Proteinuria.
You can check the 24-hour albumin excretion.
Okay, so 24-hour protein excretion. That will be the gold standard, and you have a urinalysis, and that will be the quick one. There's a middle ground where you don't have 24-hour urine. You don't have to send for 24-hour urine. You can send what we call spot urine, but still, it still give you some numbers. Are you aware of? And we're doing that, I think, most of the time in the clinic, nephrology clinic. Rashwin, no?
Sorry,
So
Prof,
have
I'm
you
not
heard?
aware.
It's okay. Have you heard of urine protein creatinine ratio? Urine PCR or urine ACR? I think in diabetes, you have a urine ACR. Yeah, okay. So somebody say yes. Yeah, so true. So there are three ways of checking somebody having proteinuria or not. One is dipstick. That's very crude. Doesn't tell you the exact amount, because to say somebody has a nephrotic syndrome, then they have to have more than 3 grams of proteinuria, right? So without just a dipstick 2 plus 3 plus, we can't be sure what is the amount. You have a 24-hour protein collection or protein excretion, that will be gold standard, but then it's troublesome because the patient has to collect urine for 24 hours. So then in the middle, you have something what we call urine PCR, urine protein creatinine ratio, which the patient don't have to collect for 24 hours. They can send there and then, but still it gives some value, which is equivalent to the 24-hour urine. Okay, so we do that a lot in the ward and in the clinic because it saves time. Okay. So yeah, so urine PCR is another one. Okay. So we're missing here. So what else we're missing, Frederick? Investigation-wise.
Ultrasound of the kidney.
Okay, why do you want ultrasound of a kidney?
To show if there's any inflammation or even the CKD picture, which is the shrinking of the kidney cells.
Okay, so CKD picture true. If the kidney is small, it may suggest the patient has CKD. But inflammation, it might not show that much, because inflammation happens in the kidney unless you're dealing with inflammation outside the kidney. Yeah, so that's all. And I'll rule out obstruction, which is very rare happening in SLE. Other investigation?
The kidney biopsy.
Okay, before we go into the kidney biopsy, any other investigation?
Any other investigation?
Go back to your differential diagnosis. You have number 1, advanced CKD. Number 2, nephrotic syndrome. Number 3.
Oh, lipid profile.
Why lipid profile? Oh, okay, for nephrotic syndrome. Okay, what else? What's your differential diagnosis number 3?
Number 3 is the number 3 is CKD, right?
But that may be number 1 or number 2. So number 1 is nephrotic, number 2
Number
is
3.
advanced CKD. Number 3?
Lupus nephritis.
Lupus nephritis belongs to under number 1, which is a nephrotic syndrome, because nephrotic syndrome can be due to many things.
Oh, the DVT.
DVT is number 4.
Number 4. Which one? Which one is number 3 already?
What cause overload?
The the heart.
Okay, yeah. So you have a decompensated heart problem. So how do you diagnose or how do you outrule that?
To check we check the echocardio.
Before echo?
To check for the before
Something
echo, chest X-ray.
Okay, yeah, so chest X-ray. And in this particular case as well, because the patient has fluid overload, so I would probably do chest X-ray as well, just in case the patient has pleural effusion, something that suggests the patient has pulmonary edema as well. Even though in the presentation does not seem to be patient having, severe shortness of breath, but the patient has shortness of breath. So when the patient has shortness of breath, you want to make sure that you don't miss pleural effusion or pulmonary edema in there. So chest X-ray is needed. Okay. All right, so I think investigation-wise, simple enough. I think those are the things that we will do. Go back to your differential diagnosis and you will see, nephrotic syndrome, you have a lipid there, you have to have a protein collection there, and you have to have a renal profile, you have to have all the wealth of investigation to suggest whether what is the cause of nephrotic syndrome, And ultimately, what you do is kidney biopsy. Okay. So let's see. You have lupus nephritis. So yes, so SLE can cause a lot of multi-organs kind of involvement, and one of them is kidney. And when you have kidney involvement in SLE, then that's when you call it lupus nephritis. Okay. Um, when somebody has with SLE and they develop, let's say, pleural effusion because of the SLE, you call it serositis. Serositis is just inflammation of the membrane, and then it causes effusion, and that's include pericarditis and so on and so forth. When it causes seizure and due to the SLE affecting the blood vessels in the brain, then you may call it lupus cerebritis. Okay, so a lot of multi-organ involvement. And for kidney is a lupus nephritis, and we do the biopsy. Of course, a good student want to remember the different classes of SLE in the kidney biopsy. There are 6 of them. But essentially, I don't think you need to remember to pass your exam. The idea that, you have to, even the MO struggles to remember all these classification. So yeah, enough for you to know that, maybe there are 6. It doesn't follow that's that 2 is worse than 1, 5 is worse than 4. So, and the most common diagnosis we have in lupus nephritis is number 4. And then that usually is one of the severe. Okay, and the reason why we do kidney biopsy is so that we know that what's the diagnosis and how to treat and what's the best treatment for this. Okay, other slides.
Yep, that's the final slide for the treatment
Okay,
and
treatment
management.
and management. Okay, so what do you have in your treatment and management, Frederick?
So aside from the kidney biopsy, I think we need to look from the staging to check what kinds of immunosuppression do we give. Other than that, it's just some form of supportive treatment. Because of the nephrotic picture, we need to give some of the fluid restriction, give the IV albumin, and some form of because of the fluid, we also need to give some diuretics also. That is what I think lah.
Okay, so fair enough. So even if you get a SLE in your final year or lupus nephritis in the final examination, don't be quick to say immunosuppression, because there's only one angle of management of certain things, right? Just like heart failure, you don't go straight to anti-heart failure medication, because you also have fluid restriction, you also have diuretics in there, you also have, what you eat, and you always have to think about, can I throw in certain non-medical, non-pharmacological kind of management like diet and exercise, or even the help of physiotherapy or occupational therapy or something like that. Now, in this particular case, perhaps there's no direct OT needed, but physiotherapy certainly, because if you have bilateral leg swelling for 2 weeks or 3 weeks and you not moving anywhere, and that can easily affect you in one way or another. So having physiotherapy to help you gain confidence again for mobility, I think you can throw it in your management as well. Okay, but yeah, low salt diet, low fluid diet, as well as diuretics is important. What diuretics are you using, Frederick?
What diuretics are? Maybe the loop diuretics.
Okay, loop diuretic. For if you want to offload somebody, you only have loop diuretics. Okay, you have other diuretics for antihypertensive, but if you want to offload somebody with fluid overload, loop diuretics is the only way forward. Okay. All right, next.
All right, I think that's okay.
Did you
These are
mention
some of the
immunosuppression?
immunosuppressant, yeah.
Okay. I think as 3.1, even as 3.3, you don't really need to remember all those different types of immunosuppression. I don't expect you to be able to blurt out, I want to give cyclophosphamide to this patient or CellCept to this patient. Now, of course, if you know, that would be great. But that's not a criteria that I use to say whether you can pass or not. Okay. But because it can help you in many rheumatological condition and kidney condition. Yeah, so knowing some or at least having heard of certain immunosuppression will be beneficial to some of you, not all of you. Okay. So let's see your long-term management. Okay, so that's good. So the management of the manifestation of SLE, I think that's good, especially if a patient has cutaneous symptoms. I think don't forget about avoiding the sun and so on and so forth. Okay, all right, okay. And I think that
that's it.
psychological issue as well is good. Always think about, so in your management, right? If you want to get a better marks apart from the medical management, always remember your non-pharmacological management. And I think you have covered a lot in here. And I think that would be good. But 3.1, I think it's easy. 3.3, because you have a lot of information on your medicine. So sometimes you tend to forget your non-pharmacological management of certain diseases. Okay. Next, other things. Okay, good.
Yeah, I think that's it for the case today.
If I may share, you don't have a chat group here, Chat. Oh, no chat here.
Oh, okay. Let me just include you as one of the co-organizers so that you can share the screen or even put something in the chat.
Okay, I want to share you with one. I think there's a book that free to download that one of my friends are doing it with, I help out a little bit on lupus nephritis. So I think it's not too much. And I think most of the information is quite advanced, but I think it gives you some simple overview of, what is SLE, or lupus nephritis particularly. So if I could share with you.
Let me just change the present to everyone first, because I could not add people to be the co-organizer. I have no idea what's happening. All right, I think you can share the screen now.
Content only. Stand out. Windows screen. So you can see now, right?
Yep.
So this is, so you can search lupus nephritis current updates this 2021 purely on lupus nephritis. But basically it's free to download. It's not illegal. Don't worry about it. It's legal download. So lupus nephritis, pathogenesis. And then even though it's lupus nephritis, they talk about some SLE as well, rule of kidney biopsy, just to make you understand a little bit. Classification, diagnosis, and there you have this criteria. So I was going to ask, I think Eugene, if I'm not mistaken, during my time, I was remembering the ACR criteria, 4 out of 11 criteria. So nowadays you have all different criteria. I think the rheumatology, some of them are still using SLIC. And if you want ACR, it's a bit more complicated because it gives marks on certain things. But yeah, so they're all there. And then for lupus nephritis as well, the different classification and compared to the latest classification that we have, you can see there. And this is just for information. I think you don't need to remember, but at least give you some overview of lupus nephritis. And there's a management strategies, and unfortunately, these are all pharmacological. Because they want to focus on pharmacological, and because it doesn't deal with somebody with fluid overload. Okay. Special consideration, you can skip this because you talk about pregnancy in SLE. And conclusion. Okay. So that's for you. You can search current updates lupus nephritis. Let me stop. How to stop? Stop presenting. Okay. Now I'm not sure. Do you have any overseas participant from here? No, just the UM.
Because we share it through our Instagram, so there might be students from other medical school or even outside of our
Overseas,
country
okay.
as well.
as compared to other people who studying overseas, I think one of the advantage of Malaysian medical students are that they're being exposed to diseases that happens a lot in Malaysia. And one of them is SLE. Okay. I think for overseas, one of the two topics that I have to relearn or I have to read a little bit more after coming back is dengue and SLE. Because yeah, so rarely we see these two conditions over in overseas. Okay, so and as a Malaysian medical student, I think SLE and dengue should be our bread and butter, because you know a lot of cases in Malaysia itself. And certainly in your final year, you will have some of you SLE cases. Okay, so it's one of a famous case for modified long case, certainly. Okay, so any question so far for about SLE or lupus nephritis or any other nephrology topic or any topic that you want to ask?
Open to the floor first. Anyone want to ask some
Okay, this is your
questions?
time. I was grilling you with questions just now, so this is the time to make a payback. Okay, Eugene.
Hi, Prof. Thank you so much for the session just now. I'd like to ask more about IgA nephropathy instead of SLE. So I just want to ask, like, in IgA nephropathy patients, what would he usually actually send in the investigations? Is it like serum IgA levels? And then
No, yeah, true. Yeah, logically, right? So you have IgA, so the IgA level in our blood should be affected. Unfortunately, not really. Even if you send IgA and it may be slightly elevated, it can be slightly elevated because of many other things. So eventually, if you suspicious of somebody has IgA nephropathy, then kidney biopsy is the answer. Now, but I think the more important thing for medical student as well as MO is that not the end part. The end part, nephrology can deal with it. I mean, doing kidney biopsy, but when to suspect that somebody has IgA or how does it present? I think that's more kind of relevant to you guys, because IgA nephropathy, I think, is one of the glomerulonephritis that presented itself with a wide variety of presentation. Okay, you can have eventual diagnosis of IgA from the easy or not the easiest, the most subtle one that I've seen is that patient do medical checkup very well, no previous medical history, and they just noted to have hematuria in the blood, no proteinuria, and they felt fine. I mean, there's nothing at all otherwise. Okay, and then that can be one of the presentation of IgA. Okay, after you rule out other stones and whatever it is, to the extent that the end of the spectrum is that somebody, like I was saying, 20-something years old, very young, playing football, everything was okay. One day, become sick. 1 week later, admitted to the hospital. Creatinine was 1,000. And when you scan the kidney, it was actually very small kidney, and the urine shows active urine, meaning that the hematuria was heavy, the proteinuria perhaps slightly there, and then you do all the autoimmune screen, they are negative. The SLE screen is negative, the ANCA screen is negative, which is for vasculitis. Because IgA, we don't have a specific blood test. So after you rule out the SLE, you rule out the vasculitis, and you probably end up with potential disease IgA. So you can see there's a wide variety of how IgA can present. It's just, how can we pick it up? And even in this particular case, right, IgA nephropathy may be one of the small differential diagnosis of part of the nephrotic syndrome, because IgA, although does not really present typically with nephrotic syndrome, usually it's a nephritic syndrome, but it can, especially when you have abnormal kidney function. But of course, I don't expect people to say IgA in this case. So IgA presented usually with the hematuria, but there's a wide variety of presentation. Okay, and it's one of the most common nephritic syndrome in the world. So if you have somebody with nephritic, saying IgA would not be a mistake.
Thank you
Right,
so
Eugene?
much.
No problem.
Yeah.
Thanks.
Very good explanation. Another question is, how about membranous nephropathy? like usually patients will have underlying hepatitis or some infection, and then subsequently will have this renal problem. Is it? Or what
Okay.
is the usual clinical picture?
So again, membranous, you're 3.3, right? So for those who doesn't know, membranous is just a biopsy diagnosis. So again, if you rewind a little bit, okay, so the presentation of somebody with membranous is usually nephrotic syndrome. So for example, in this case, 44-year-old nephrotic syndrome, one of the possibility is membranous. Did we mention it in the differential diagnosis? We did not mention it directly, but it belongs to the group of nephrotic syndrome. So under nephrotic syndrome, you have primary and secondary, and under one of the primary is membranous nephropathy. But why is this not membranous? Because I think the SL is more clear cut because you have low complement level, which membranous would not have. You also have positive ANA, which membranous would not have. But just beware, just to make things confusing, the class 5 SLE is actually membranous, right? If you go through the Frederick kind of a classification of so SLE can also have some membranous component, especially in class 5. So when Eugene was mentioning, hepatitis and infection, whatever it is, so like any other kind of a condition, so usually when you have something like membranous, 70% of membranous cases, when you do kidney biopsy, you see certain features of membranous. 70% of those are what we call primary. There's no specific kind of a reason, you just have an autoantibody and you develop membranous. About 30% of these patients actually may have something else that trigger them to have membranous. And that would include SLE, which if we have mentioned class 5 SLE. Hepatitis B is one of the infection more commonly associated with membranous nephropathy. What else? Cancer is big top as well. Can be associated with membranous nephropathy. Okay. So that's up to us how to investigate, how do you know this is primary or how do you know this is not because of a cancer? I think that will be advanced level of nephrology discussing. But in your case, I mean, thinking about membranous as part of the differential diagnosis of nephrotic syndrome, I think that would be good enough.
Thank you so much, Prof, for the answers.
Thanks, Eugene, for the question.
All right, if there is no more other questions, then Prof, would you like to give us some final words on how to study nephrology and what are the things to expect for clinical student on the exam or even the preclinical student? Let them be prepared when they entering clinical.
Number one, I would say, don't be bogged down to the detail part. Okay. When I was a medical student, whenever I hear nephrology, what I'm thinking is all glomerulonephritis. I have to look into a microscope, C3, C4, whatever complement. Nephrology is bigger than that. So most of the time we're dealing with, in a real case scenario, we're dealing with somebody with, AKI, somebody with CKD. That's more common than the glomerulonephritis that we usually are exposed to. I think that's number one. And number two, I think if I'm teaching somebody about nephrology, mostly I will try to teach based on I'll focus more on the understanding instead of memorizing. Because even the topic of AKI, mostly because AKI is because of something else, it's about, understand why somebody has AKI. I think that for me, I think that's more important instead of memorizing, 6 stages or 6 classification of lupus nephritis, which is good, but I don't want you to miss the main bulk of, how SLE presented itself and when to think about somebody has SLE. And I think generally, if you come to our ward, ask questions. I've seen people with a black scrub suit. I mean, we do that as well when we're medical student, afraid to approach lecturers, afraid to follow the ward round. Follow us. I mean, we enjoy having students, and that's why most of us are lecturers, because having students follow us, because sometimes we do ask, daripada mana, or where you from, what stage are you in, any question or whatever. But if you become more proactive, we'll be really happy joining ward round. And I know ward round can be very some of us may think that it's a waste of time. And I do think that if you stay 3 hours for ward round without gaining anything, I think probably it's a waste of time. But in order to prevent you from wasting your time that way, and I think going through the grand round really expose you to the language the doctor speaks. You want to identify that. I mean, most of the consultant over there is your examiner as well, and most of the question they ask their MOs or their housemen are the main question that they will ask their medical students as well. So getting you familiar with the lingo or the language that they use, I think that's important. And looking at the blood result as well, you have a laptop in front of you. When they're discussing and looking at the blood result, asking your MOs or asking. So overall, be more proactive when you do the clinical ward round, so that you can get the best benefit instead of just being passively, following the round. Even if you're afraid to ask directly the consultant, I mean, the HO are there, the MO is there, the specialist is there. Identify few people that will be able to help you, and I think you enjoy more of the ward round and being with others instead of doing your own stuff and preferring looking at the notes or whatever. Okay, I think that's 3. I think that will be enough for now. See you in the clinical then.
Thank you, Prof, for giving us. Oh, there's
Somebody
someone
raise
for
your
one.
hand. Yeah.
Hi, doctor. My name is Owen. I'm a second-year student. Thank you for your advice. I have a question regarding the investigations. I noticed that there were high troponin levels, but I can't seem to think why. Could you share
Why?
some?
So what do you think troponin is for, Senwen? Owen?
I think usually if we have elevated troponin, we think of an MI, right?
Mm.
Yeah. So I think that's
Okay,
the
true.
first
Yeah,
thing.
so exactly. Troponin usually in situation, we only use troponin as an indicator of MI. Okay. Now, we send a lot of troponin even in the cases where we don't think it's a MI. So for example, in this case, you have a bilateral leg swelling, but because the patient has shortness of breath, and shortness of breath can be one of it is MI kind of a presentation. So I suspect maybe in this case, they suspect MI as well. And this is a good case to show you that you cannot just trust the lab. You have to link in everything in the investigation as well. There are people who has elevated CRP but not actually having infection, and there are people who has fever but not having infection, like SLE patient, right? So they can have fever as well. And there are people who have elevated cardiac enzyme but not necessarily having ACS. Okay, so you have to tie in with the presentation, and you have other explanation. So for example, in this case, troponin I or troponin T, where's the troponin just now? Yeah, high sensitivity troponin I, low level is 30. If somebody has a kidney problem or some CKD, you can have elevated troponin I without actually having a trop I, without actually having a cardiac heart attack. There are other reasons. For example, severe sepsis can also trigger elevated troponin I without actually mean that the patient has NMI or ACS. Okay. So yeah, so in this particular case, I know it seems elevated, although the level is not that actually high. You can see. So that's why if you follow rounds, for those with MI, they may have multiple, or they may have a the high sensitivity troponin I may be like in hundreds or thousands instead of just 89. So that's how we know that unlikely for this patient to have ACS, and more relevant for us to think about SLE and the rest of it.
I see. Thank you so much, doctor.
Okay, hopefully that helps Owen. Medicine somehow, unfortunately, is not black and white. It's never going to be black and white. Whatever you read in the book is good to have a basic knowledge, but there are give and take of certain things. And the more you do medicine, the more you talk to the patient, the more you deal with multiple different level of problems, then the more you be able to identify which one is more relevant and which one is less of a relevant.
Yeah, in the big sea of medicine knowledge, the only thing we can do is being proactive and actively pursuing what we wanted in this sea of knowledge. So thank you, Prof, for
Is
giving
that
us the
from
guidance.
is that your words or is that you're reading from somewhere?
No, I'm not reading from anywhere. I'm just using your words as proactive and then think of, because I'm always experiencing, wow, there's a lot of things to learn, a lot
True,
of things
yeah.
to study.
As a medical student, you can read actually whatever it is. You can even be better
Yeah.
knowledge than the consultant. But I think at your level, what's more important is that what is relevant to you. Because even at my level, I can read SLE mechanism like to the extent that I don't really understand. You can go really into detail of those. But is that relevant to my day-to-day practice? Perhaps not, unless I'm doing certain research on it.
So in this sense, the only thing that we can really be good in certain things is we are actively pursuing the things that we really needed in our daily practices. So that makes us a better medical student and even in the future better HO, MO, and even the consultants. Yeah. So anyway, I think our time ended. So thank you so much, Prof, for willing to give up some time to help us out in this discussion on lupus nephritis. And thank you everyone who willingly to participate in such a lovely Sunday night. Yeah, thank you everyone.
Okay, thank you everyone for around. Just say hi if you meet me in the PPUM as well. Okay, thanks.
All right. And for the participant, don't forget to fill in our feedback session. So we want to know more about what you feel about this session so that in the future we can make it better. Thank you so much for joining in and
Okay,
see
thank
you
you,
for the
MEDSOC.
next episode.
Thank you, Prof.
Thank you, Prof. Thank you, Frederick.
Thank you so
Thank
much,
you, Prof.
Prof. Thank you, Frederick.
Thank you,
Thanks,
Prof.
everyone.
Oh,
Night.
now I can hear a lot of voices. How come early on there's no voices?
This is how I like as an online medical
No
student.
worries. Okay, Frederick. I was once a medical student as well. Okay, bye-bye.
All right. See you soon.